Spine Institute broadcasting live spine surgery. Our patient is here with herniated discs at L4-5, L5-S1 with annular tears. He has pain on the left side going down the left leg. So we're going to be treating the left side. I think we have an orbital issue for some reason there, but it's just minor. Anyway, I'm talking to my x-ray tech, Monica. Oh, it's worse. And maybe that's the best we can get. We use x-rays. That's worse. We use x-rays to guide our treatment to the spine because the spine is made out of bones, and we have to have a way to navigate. You can go ahead and do a 3-2-1 if you haven't. Oh, yeah, we already did. So at the beginning of the surgery, we need to get the x-ray and the patient lined up perfectly so I can navigate perfectly. I'm going to start by doing some numbing medicine on the skin. You're going to feel a little stick and burn, okay? Don't freak out. That's just some numbing medicine. It's going to hurt a little bit. Yeah, you're good. You're good. Everything's okay, I promise. So people's response to pain really depends on a lot of association areas of the brain and how they perceive pain. And that's where anxiety and pain meet. In those areas where anxiety increases the response to pain and less anxiety decreases the response to pain. All right, we're going to get started. You let me know if it's uncomfortable, okay? All right, so we start by left side, since his pain in his leg is on the left side. And I'm going to access the spine. Remember, using the x-ray machine. So we're going to start at L5-S1. It's always the hardest one to get to. Shot? Yeah, he's nice. Very nice. You're doing great. Shot. Hang in there, buddy. You're okay. Shot. Uh-huh, good, yeah. Yeah, we're nowhere near the nerve root. We're nowhere near the nerve. Shot. What was that? Shot. All right, so I'm on the facet complex at 5-1. And let's just get an AP to verify that. So our approach with the Deuk laser disc repair is something called transforaminal. When transforaminal means rather than the traditional way of going translaminar, which is in the middle of the spine, we're approaching the spine from the side. And the reason we do this is, number one, it doesn't cause any collateral damage. We don't have to remove ligaments and muscles. We don't have to cause scar tissue and pain. No bleeding. So it's all done minimally invasive through a hole that's already existing in the spine. Shot. You're okay. Shot. Shot. Okay. You're doing great. Just hang in there. He's got some pretty good sized facet joints. So I'm going to have to go a little bit more lateral. I may have to start a little more superior. Shot. Because his iliac crest is getting in the way. You're okay. Shot. Definitely iliac crest getting in the way. Yeah. Shot. Uh-huh. All right. We're going to start a little bit more superior and possibly, yeah, right about there. And the reason for that is the iliac crest, this pelvic bone, the skeleton bones, is just getting in the way. Shot. So I need to try and go more from the upper area. You're okay. And give him a little numbing medicine. Come on. All right. Did he move? A little bit? All right, let's try to refocus that. Shot. It's definitely better. Still hitting his facet. AP, just to verify. Definitely has congenital stenosis. Short pedicles. Looks like a relatively anterior spine. That's it there? All right, lateral. Definitely not hitting the pelvis now. We must be hitting the facet. You can actually see the giant facet joint right there. So you're doing fine, just lay still. Otherwise the trajectory looks good, so we'll back it up. We'll go a little bit more anterior shot. Still not enough. We have to go, what? Everything okay? Shot. Shot, yeah, he's just got massive facets. It's literally blocking my way. Have to be a little bit more lateral. Keep him comfy. Shot. Shot. You're good. Shot. You're good. That's definitely the pelvis. Shot. Shot. Unfortunately, it's just a matter of trial and error to get to the right spot. Shot. Again, same thing, facet. Shot, same thing. How's he doing? Good. Yeah, I'm sorry. This is the worst part, Sean. Yeah, you're doing really good. We are going to put you to sleep at some point, I promise you. Yeah, you're doing really good. And I apologize, you have to be awake. But that's the best way and safest way. That's you, I'm looking. You comfy still? All right, I think we finally got it. Sean? Well, that was right till the end. And looking pretty good. Shot. So, you comfy? Shot. I feel the herniation now. Huh? Shot. Not bad. How much of your problem was back pain versus leg pain? 4551? Okay. Well, we're almost done with torturing you. So for the people watching, this is endoscopic spine surgery at its finest. It's called the Deuk laser disc repair. All endoscopic spine surgeries are a little bit different. And this is called the Deuk laser disc repair because we pioneered the technique here at Deuk Spine. So far, the technique we're using is pretty similar with everyone else. Okay, we haven't done anything dramatically different. We have a patient prone, awake, propofol sedation, their back sterilely prepped and draped. The approach I'm using is a standard approach. All right, let's look at, see the back of the vertebral body of 4? See the double shadow there above the pedicle or by the pedicle where the pedicle enters the vertebral body? Let's see if we can get that lined up a little bit better. I think your 5 pedicle's good, but I think the 4 could be a little bit better. Let's see what we got. Yeah, it's an orbit thing. I can't tell. It almost looks worse. I don't know. What do you think? Worse?
Let me try the other
All right, that's fine. You know what? That's probably as good as it's going to get right there. So let's just stick with that. All right, so we access L5-S1 disk through a transferable approach. And the only thing I've done is make a little cut on his back, 7 millimeters. Okay, that's the whole incision for the surgery. Now we're going to get into the L4-5 disc. And once we've done that, we're going to put him to sleep. Shot? Well, that's partially true. We do need to do something before he goes to sleep, right, Louise? Shot? And it has something to do with music from the 70s. Shot? You're doing great. What kind of music do you like? Huh? Slayer? That's definitely an 80s.
I like it.
80s band. You like Metallica? Huh?
He said, oh yeah.
Yeah, me too. Not everyone. These younger.
Wedding song. It was they're great.
Which one?
It was.
Enter Sandman?
Yes, it was.
No way.
No.
Unforgiven?
No, it was Nothing Else Matters.
What?
Metallica.
Oh, I love that song. That's such a beautiful song.
It would be great if it was like the Unforgiving Enter Sandman.
You know, I would have done that for my wedding.
Or something.
I don't like speed metal.
No.
I like.
Yeah, and they have a version of it that has a lot of like violins with it, and that was the version we had. So it's kind of like this.
I really like how they bring that symphonic orchestra in with the drums and the guitar. Shot? Yeah, definitely.
For our 7th anniversary on
Shot?
Etsy, I got a lady to custom make this huge thing of Metallica lyrics that's
Shot?
in our entryway now. It's like 7 foot
Shot?
by, oh, it's big. I forget the exact thing. I think it's 5 by 7.
What is it, like a tapestry?
Like no, it's like she painted it on like a piece of like kind of looks like farmhousey wood. One of those like very HGTV would like it type of thing.
Yeah.
But it has Metallica lyrics, and it looks really cutesy, but it's Metallica
Shot?
lyrics, so it's kind of fun.
Shot? You okay, bud?
You'd think it'd be like one of those lick, laugh, love signs, but it's like Metallica.
You feel anything? No? So I'm bouncing on the herniation right now. Shot?
Everything. Oh, Post Malone. No, you do like everything.
All right. Are you comfy? As much as you can be for somebody sticking needles in your back, right? All right. So 60% was back pain? How bad is that on a scale of 1 to 10? How bad? 9? Is that where you typically get your back pain? Okay, all right. We just found one of your bad discs for sure. You better now? All right. If you need to get upset with anybody, get upset with Flynn. You want me to spell that for you? All right, where's the other one? All right.
Is it easing up there, Sean?
Okay. All right. Well, we know we're here to fix 2 discs, so can't even get it out. Let's see. Shot. Interesting. Huh? No, it's not coming out. I don't know if there's too much scar tissue or if I'm up against the end plate. Oh, there we go. How bad is that on a scale of 1 to 10? 11. All right. All right, folks. You get to go to sleep now. We're done torturing you. You can just count out loud from 1 to 100. What other languages do you speak besides English? Huh?
Just English.
Just English, okay. Count out loud in English from 1 to 100. Start counting. You get to go have some nice dreams. When you wake up, your surgery will be done. Go on. So, marker. Let's get the lighting right. All right, folks, for those of you watching, we're going to do the whole surgery through this tiny little 7mm cut, 1/4 inch. He has 2 herniated discs. One is at L4-5, the other one is at L5-S1. And he has this tear in the back of the disc called an annular tear. So I just tested these discs to see if they were causing his pain, and they were. The top one is an 11 out of 10, and the bottom one was a 9 out of 10 pain. And it's his typical pain he gets every day. So we have found the source of his back pain. It is those 2 discs. We're going to fix them for him. So when he wakes up, those pain will be gone for the rest of his life. Shot? I've just got to advance the guide wire and pull out the out the needle. Once I get this out, we're going to use the guide wire to guide our next tool, which is a dilator. Dilator will take a look at this thing. Can you guys see this? See the tip of this? Can you zoom in on that? Zoom in. There you go. It's like a video game. Keep going. All right. Everyone wonders what this thing looks like. But if you look at the tip, it's basically tapered. What tapered means is it comes to a point. And this tip spreads the muscles open. Spreads everything in there open so that it's gentle and it gently spreads apart the tissues. And the place it enters the spine is actually where the tear is in the disc. And that's the same tear we're trying to fix. So it doesn't do any damage to his body. It spreads the muscles and the fascia. And then when it gets to the bad disc, it goes into the disc right where the tear is, where the herniation is. So it's pretty ingenious technology. And like I said, he's a little lighter than I want him. I didn't develop this part. This was all developed way before me by Dr. Parvis Camden in Pittsburgh, who developed the transforaminal technique. And then, of course, there have been a few other adopters, early adopters of this technology, like Dr. Anthony Young. And lay still. Dr. Young is really the main one. And then, of course, over in Korea, some of the Koreans adopted it. And they have been doing transforaminal surgery for years. That's where I learned it. There's been 1 or 2 German surgeons. There's been 1 British surgeon. All right. So L4-5, we need to get the pedicles of L4 lined up better. It's a WAG issue. I think you need to go north on mine. How's he doing? Bring my side north and take a shot. Once again, we're having to adjust the fluoroscopy unit. That's good. And it's an orbital issue by 1 degree, which just pick a side. I think your side may be down. I don't know. That's worse, I think. Shot. I don't know. Hard to say. I can't tell if it's better or not. Shot. It looks about the same, but it's okay. I think it's still a WAG issue, but you know what? I think we're good. I think we're good at this point. We're certainly closer. Yeah, so he's still a bit uncomfortable. Just lay still, you're fine. Is that the latest? Okay. Yep, I agree. Let me know when you're ready, doctor. So as I'm doing the surgery part, my anesthesiologist is trying to put the patient to sleep, make him comfortable, but not put him too deep, because we don't have a tube down his airway. So basically we want to just carefully put him to sleep slowly and gently to where he doesn't respond to the surgery, but at the same time he's breathing and ventilating on his own. That's better for sure. Mild response. Shot. All right, I think we're where we need to be from an anesthesia standpoint. So I am going to proceed. Now we're going to take this dilator and go right through that tear. Shot. So you can see the tear right at the tip of the dilator. It's the black stuff coming out. You love to knock things over. That's one thing I have learned about you. Just drugs. It's funny. Shot. Hey, no ambulance, no foul. That's what we used to say playing basketball. Shot. 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 Let's go AP. Yeah. I don't know what it is today. I'm just not happy with that. Let's pull it back a little bit. I want to redirect. That's not how you hand the instrument to me, okay? All right, so watch. Now what? I'm going to do this. That's correct. Shot. 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 Give me an AP. Shot. It's definitely looking better. We need to go more medial though. Give me that. Shot. Can't see. Let's go AP. Shot. All right, I think that's pretty good. I may want to, let me see. I just feel like we can do a little better going medial more. But what I can do is I can just reposition the tube once we get started. There just may be a lot of scar tissue. It's kind of forcing me lateral on the disc. So once we get in, shot. Once I get in, I can always redirect more medially. Shot. That's good. Move the fluoro out. Now you cannot keep the fluoro in. Okay. So we are starting with L4-5. And then we'll do L5-S1 second. So right now, we need to go in with our scope, find the herniation. Damn it. Watch it. Damn it. Take that. Fucking thing. It's supposed to be here on this side. Good. Oof. This cannot come off. Okay, this cannot come off. So your job is to always be watching what I'm doing, my equipment, make sure it's all ready for me and it's ready to be used. I shouldn't have to stop what I'm doing to fix the equipment. That's your job to make sure it's right. You understand, Flynn?
Yes, I understand.
So you got to take that serious.
Is the red thing at?
All right, laser.
Oh, check that on that.
Okay, we are inside the disc, just kind of lateral in the disc because of what I told you earlier, the scar tissue. And we're now bringing the laser in. This is all herniation inside the disc.
I asked Chad if he could please calibrate.
What is it? You asked Chet what?
If he could please calibrate this because he's differently to the side of it.
Calibrate what?
This little screen that changes the view of the screen. So despite hitting it, it doesn't necessarily like hit the button. So Sunny had done it recently, but I don't know. I'm not an IT professional.
You're talking about the Crestron screen.
Right, yeah.
And the Crestron screen needs to be recalibrated
Correct.
because when you touch the button, it what?
Well, you touch, like, you have to touch, like, an inch to the right of the button to actually hit the button to press. So,
So where you touch is not where it's registering.
right.
It's not registering where you're touching it.
Yeah. See if the,
Yeah, so exactly as I had said.
sometimes it randomly just shuts, especially this one.
Shuts what?
It'll randomly just shut the TV off, too. So I let him know, I wrote up an IT ticket about it just a little bit, like, an hour ago. So he's
Okay.
approved it, he's gonna work on it, tomorrow. And
So, Chet, the Crestron stuff is Troy. Okay?
Correct.
yeah, so he's aware. So,
I've never heard of the Crestron screens needing to be recalibrated, but
Sunny apparently did it like a month ago, like right before,
uh-huh.
but it's right back to where it was. So
Mm-hmm.
no.
Luis, again, there's issues here with the lens. You see it?
Is that 12?
Yeah. Yeah. That hazy area. I mean, have you played with these and made sure they're completely clear?
Yeah, we checked them. I mean, I'm blind, but I asked him if
The
it's
white
fine.
balance looks beautiful.
Yeah, but it's a little blurry. And I can't even focus it. See that? I'm literally focused to the max. Yeah, definitely at 12 o'clock there's an issue.
I see over here.
Yep. So we need to have this looked at. And it just goes,
I already sent an email in between cases to them to see, yeah, but if I don't receive an email back, I'm gonna call them and ask another glue. I already sent an email to Richard Wu to find another glue. I know the glue on the other side.
this is so incredibly scarred up. And that's why we're being forced wide out of the onto the wider lateral part of the disc because the medial stuff is so hard. So it's like cartilage. It's like thick cartilage. Mm-hmm. Yeah, this disease that causes back pain is an inflammatory disease. So It's inflammation you're dealing with. If somebody has 10 years of back pain, it's 10 years of inflammation. And inflammation is not supposed to go on for more than a few days after an injury. So when you have a body part that's inflamed for 10 years, that means it's been making scar tissue for 10 years. And 10 years of scar tissue is going to be a lot of scar tissue. A lot. And that's what we're dealing with. This is all like solid scar tissue almost. You can see a little bit of blue in there. That blue is the herniated nucleus. And that's what's causing the inflammation. The interaction of the blood vessels with the nucleus pulposus generates inflammation. The nucleus is pro-inflammatory. Good job. Finally got it right there. So, oh yeah, there's a big chunk of collagenized herniation. Alrighty then. Yep. So this simple little tear in the back of the disc called an annular tear is the actual source of all the pain in people with herniated discs. Are you able to run a video? Guys?
Yes.
All right, can you run the lumbar or lower back pain, the cause of lower back pain video? So our audience can see what I'm talking about.
We are running it now.
All right, good. Yeah,
Traumatic
just always
injury
say
to the
start.
disc can cause
That
annular
means-
tears to
That
form.
means they can't hear me, so that's fine. Then I know. Then I can yell at people.
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Van Loveren?
You're live.
All right. Welcome back. Hopefully you've enjoyed that video and explains a little bit about exactly how the annular tear and the herniation cause back pain. And that's why we're here fixing this right now. Because the annular tear is the cause of back pain, we're able to cure that back pain by debriding the tear, getting rid of the source of inflammation. Did you do neuro when you were at Tampa General? Yes. And Van Loveren was the chairman, right? Harry Van Loveren?
Sounds familiar.
Yeah.
That was very stressful.
What's that? Neuro
Well,
or just residency?
the whole residency really.
Yeah, it always is. But you made it, right? I hope.
Yes.
Good.
My sister's doing her residency where Dr. Amada did a lot of med school.
Who?
My sister is doing
Yeah.
her residency where Dr. Amada did a lot of med school.
Oh, really?
Yeah, up in Akron, Ohio, it's a branch of Cleveland Clinic.
Uh-huh.
She's in general surgery.
Okay.
She's
General surgery?
Or she's like, this was the best day ever. This is so much fun. I love it. It's like going home to school.
Yeah, it's pretty much like that.
I have to do a leg out today. I'm like, okay, good for you.
What year is she?
She's her first year.
Oh, okay.
She's young. She's very young.
She's an internship then. Yeah. The nice thing is when you're an intern, you usually rotate, you know.
Critical care thing. She gets a lot of experience, it sounds like, so she really likes it.
Uh-huh. Good. What does she want to do when she's all grown up?
She isn't really sure. It seems to change on the, like every week or month or so, but she really likes critical care and she really likes trauma.
Trauma surgeon. It's not bad.
Yeah.
I had a guy in my med school. There's the tear, by the way. His name was Neil Chatterjee. Neil Chatterjee. This is a USC med school. And Neil was a really good guy, but he didn't really study at all. Instead of studying in med school, he would go surfing, you know, in Santa Monica and Malibu. So in med school class, everyone's in class and we're taking notes, and Neil wasn't there. And he would literally show up, because we took exams every week, so USC in Los Angeles, we took exams every 8 weeks. He would show up. So the exams were Monday, Wednesday, and Friday, all day. He would show up on Saturday and say, can I borrow your notes? I got to start studying. And he would literally live, which I lived there too, but he would live in the study hall with his blanket. And he would just stay there, and he would just get C's and barely pass. Then he got 2 years of that. And, you know, we're like, Neil, you're barely passing med school. You know, what do you want to do? And he's like, I just want to be a general practice doctor, you know, like primary care. And then he goes to his 3rd year and he does his rotations. You know, OB-GYN, internal medicine, all the usual, pediatrics. And then he does surgery. And they put him on trauma surgery. And he comes out of trauma surgery and he's like, oh my God, I want to be a trauma surgeon, right? But you got to have good grades to be a trauma surgeon. Otherwise, you just forget it, you know? But they loved him so much at USC in trauma that they gave him a spot in residency.
You kind of need like a calm person to do trauma too, so maybe like his surfer vibes kind of work good for him.
Absolutely. Absolutely. Neil is this big Indian guy with long dreadlocks.
Oh yeah, he'd be a good trauma. I could like picture it.
Right? And then he's like, he has the biggest I don't give a shit attitude.
Yeah.
And then he gets to trauma surgery and he's like, he becomes like a freaking puppy dog.
Oh yeah.
He was like, oh my God, I love it. And he was like spending extra hours. He never go home, just sleep there just so he could go and do trauma surgery. So basically he figured it out, you know, and I'm happy for him. And they liked him, so in the end the grades weren't a problem. I think they saw he had the potential. After all, anybody that goes to USC med school, I mean, you know, top in the country in college, so clearly he had the ability, he just didn't apply himself until he found what he wanted to do. Yeah, but trauma surgeons, we were up all night long, every single night, 365.
I'll text my sister, like when I wake up in the middle of the night, I'll text her back something. She instantly will be like, hi, I'm back. Like, I'm always up, like,
Oh yeah,
she'll be on call all the time.
there's no rest for those guys. Of course,
Whenever her weekend's off, she's like, can I play on the seat over until you want to sleep? I'm like, I'm fine.
yeah.
I can sleep on the plane.
Listen, as a neurosurgery resident, we would put in 110 hours a week awake. Yeah, I'm sure. And sometimes 120. And I'm not talking about sleeping. I'm talking about working 120 hours a week. Easily.
Oh
Really? I almost fell asleep several times, especially like cardiothoracic when I was holding the heart, because you're so bored and you're literally like your arm is sticking between the surgeons and you're like this for an hour and a half. And you got a surgeon here, a surgeon here, a surgeon here, a surgeon here, the fellow, the resident, and you're just like in between them holding the heart. It just sucks so bad. And they're sewing, you know, the blood vessels on the heart with your holding the heart. I mean, it's easy to fall asleep like that. You're exhausted.
Did that girl fall like into the field or was she
Huh?
go back? The one that fell asleep that you saw? Oh, I saw. Oh my god.
Oh, we've had residents fall asleep. We've had residents fall asleep and fall. No, literally pass out. They fall to the ground. That's why they made those rules, you know, 80-hour work week for the residents. They took away those 110-hour weeks.
Yeah, but they fucked the rules.
Huh?
They still take
Half of the programs follow the rules, the other half don't. Our chairman made us.
that they can have longer weekends then. They'll be like, oh, we're 4 weeks here and then
We get 1 week off the whole year and do 110 hours a week all year. We had one resident intern year, because you know the interns all kind of hang together. It doesn't matter if you're neuro, you're ortho, ENT, whatever, plastics, general. We all kind of hang out together the first year because we all do the same rotations. We had this one girl who was rotating, you know, female or general surgeon, orthopedic. Anyway, she kept calling out. So finally, one of the other residents said, I don't care if you have meningitis, you better be there tomorrow for your call, right? Because we're sick of covering your call. So she was there with an IV pole, pushing it around the hospital, taking call, getting antibiotics. It was pretty funny.
there's a girl on Instagram that has some rare form of cancer, and she's a doctor, and she has like a Groshong cord and then a Mickey button, and she goes into patients' room with like a, she has like a backpack that she somehow has her pole on. The patients will ask her, "Are you healthy enough to meet my doctor?" Like things like that.
Yeah.
I forget what kind of cancer she has. I'll have to look her up.
Well, amazing that she still wants to be a doctor, you know?
Very motivating, and
Yeah.
she seems like she does a really good job. She works
That's
obviously
great.
in oncology, so she's young too. She's like
All right.
early 30s or like late 20s.
We're done with this disc. Grab her. And we're going to move on to the next one. Just want to make sure.
On Instagram, you know, I don't know if Instagram's kind of fake, but
Let's see. I'm going to see if I can just get a little bit more here. So that's fat right there. Do you have any questions from the audience, by the way? Guys? Because if you do, you're supposed to just tell me I have a question. Just announce it and then ask it. Who's in the broadcast room?
No questions at this time.
No questions?
Nope.
All right. Take. So, good. Done with the first one. Let's see. You know what? Let me try to get a little more. Hold on. It's kind of hidden by that bubble of fat. Let me have a laser. Watch yourself. Who? No. Jeez.
Literally
He,
trapped right in her head.
he's a general surgeon, obviously. Gas. What do they call it? Colorectal? Colorectal surgeon?
Yes, we did a software gas surgery that day.
Uh,
As a resident.
and he threw something at you?
Yes.
He was mean, huh? Why was he so pissed at you? Maybe he thought you were somebody else.
Yes, that was it.
Okay. Maybe.
I don't know. You seem very nice.
When I was a nursing student, we were doing an open nephrectomy, and the general surgeon who was just, pulling back everything, she got so mad because there was a scrub tech who was like a student scrub tech in there, and he didn't have her instrument correctly, so she threw the whole nail stand over.
See?
The whole entire.
At least I'm nice to you.
Yeah,
Okay?
it could be.
Don't push my buttons wrong.
Like get, all the new, like, everything start, and the patient's like open, and there were kidneys there. And I was just like a nursing student, like, oh my god, let me just stand by the wall.
Well,
Here.
a lot of people don't understand how stressful surgery is. And so we have to focus on what we're doing. We can't be distracted. And, when things don't go, people don't do what they're supposed to do, then it creates anxiety, tremendous anxiety for the surgeon. And so they respond to that anxiety with fear and anger, which, I'm guilty of it myself, not throwing things, but feeling that way. So it's no natural, but you still got to try to be nice. All right, I think we're done here. Keep saying that, and then I see just a little snippet more that I can get. Just want to make sure he's very happy with his results. All right. Scope off.
Another resident with me that day, and she ended up crying. Oh. Crying. What did I get more?
What'd she say? I'm not what?
She said, I can't take anymore. She said, I'll take it off.
Did she take off?
Did she quit? Oh, that's sad.
Yeah.
Yeah.
It is stressful. Woo. That's why I'm hard on my kids, because life, if you want to be successful in life, you have to be prepared to take on a lot of stress and deal with it properly. So I'm getting him used to it, the real world.
Does Arius want to be a doctor?
Arius wants to be a Formula One world champion.
Other than Formula.
I don't know. He's going to Princeton.
That's so exciting.
Yeah, but I don't know what he wants to do long term. Sometimes I have mixed feelings about medicine. It's hard. Very stressful. Not that he can't do it. He can certainly do it. He's tough. You gonna go lateral? You're killing me. And then you got to deal with Monica.
Sleeping over here.
Huh?
Said sleeping over here.
All right, what's going on? Are you hitting something? The arm board? What are you hitting? What's she hitting?
It's over there.
Hey, we need help. What's going on? I wonder what you're hitting. What do you think? Good? You good? Elise, can you just leave that there, please? Just leave it there. Yeah. All right. Yep, sure. Why am I not seeing anything?
Can we flip the screen?
All right, so. Shot. Alrighty then. So, next L5-S1. Do not put your hand there like that. You don't want to get stuck. Shot. Okay. Guide wire is there. Yes, shot. I see it. We're good. Taking the thing out. Hey, by the way, I wanted to remind you that for the rhizotomy,
Yeah, only one needle.
well, one needle is enough. Is good,
Yeah.
but you can also use regular 18 gauge. You don't need to use the expensive ones.
Didn't he use a 22 3.5 the other day, Luis? I think he did.
We can try the.
I don't think you're using a 22 because you got to put the guide wire down.
The guide wire can.
Oh,
Yeah, yeah.
So it's probably an 18.
asked for a 22 3. Maybe it was.
You see what I'm saying though, Luis? You don't have to use that the other long one. You can use a shorter one. But you can try it at least. See, shot. All right, so we're bringing the dilator down. We've already finished one of the two discs we're fixing today. Now we're going to fix the second one. Shot. Should be pretty close. L5-S1 is the hardest to fix because the space we have to do this is very small. It's a very, very small window. Shot. Okay. Let's try. I see the guide wire. I'm going to pull it back just a little bit. Shot. That's better. So I need to angle this a little further down. Shot. And maybe even a little more medial. Shot. Okay, and keep going. Not too bad. Medial and down. Shot. Just some patients have a really steep angle, you know? And this is one of them. Really steep. Good. That's fine. That part I can live with. So we've now advanced the dilator into the disc space. We're going to bring our tubular retractor down. Shot. Keep an eye on the dilator tip. Make sure it doesn't advance. Shot. Not bad. Getting close. I think that should be it. Yep. Shot. Let's do it. Thanks. All right. I need to step where you are. Nothing unsterile is being brought on, right? This is clipped. I think we're ready. Our pumps are going good. For some reason, I don't have any irrigation. There it goes. No problem. No problem. No problem. Scope on. Scope on. Beautiful. So clearly we're in the disc. You can see the end plate there on the right at 3 o'clock. And you can see the tear right there. That's the annular tear. The blue and the white and the red. So these surgeries are extremely patriotic. Red, white, and blue. You see the red, white, and blue? Okay. Perfect. Let's do it. Everything okay, guys? When do we do our next rhizotomy? Wipe. Okay. Oh, I need the laser on. I'm gonna have to give you a bottle of Prevagen. You know Amazon is selling that stuff now? Well, but she knows it. She's like falling asleep. But she's working hard. So what do you want me to say? Don't say that. Listen, my wife is always joking about me needing Prevagen. She's so mean.
Well, isn't your birthday the 5th?
Yes, you got good memory.
What if everyone in the building gives you a bottle?
You guys better not get me Prevagen.
That would be hilarious. You get like 50 bottles of it.
Hell no.
Lose her mind.
I'll get it for you, Dr. Deuk, and then you can share.
No. Don't you dare. It's bad enough that I have diabetes. I'm not accepting any other medical conditions. My brain is working fine. Sarah.
Mine is better since I got off the Diet Coke, to be honest. It's so good for you.
I'd have to disagree with that.
No, that's no joke.
Really? You think the Diet Coke was hurting your memory?
Aspartame was like eating away your brain.
I used to drink a lot of Diet Coke. I've cut back in the last couple of years.
7 days a week, 24/7, and I'm not.
Really? You like wake up in the morning?
Oh, yes, yep.
You guys have any questions from our audience? It's hard to believe there's no questions. Man, we used to have questions throughout the whole case.
Well, we are talking about Diet Coke.
No questions at this time.
Nothing?
Yes, sir.
All right.
I went a full year. I used to drink a lot of Diet Coke, not that much, but like in the afternoons I would. And then I went a whole year of only black coffee and water, and now I can't even stand Diet Coke. It's like sweet and sweet. You can't drink it anymore either.
Well, the blue stuff is the nucleus pulposus, and that's the jelly from the center that's pushing out through the tear. And with the effects of inflammation, it's turned degenerated, so it stains blue. Healthy nucleus pulposus does not stain blue. It stays white. So all the blue stuff we know is degenerated. We know the end plate is over there to the right of the laser. And for those of you that are interested, the laser fiber is made out of glass. And it transmits the laser energy from a big machine sitting at the patient's feet. It's the size of a giant suitcase. And it generates the laser beam, which we use to vaporize tissue. Pathological tissue. We call it pathological tissue. Pathological tissue. Hey, is this the same scope? Oh. I was going to say it's healed. Pathological tissue is damaged abnormal tissue that causes disease. So disease tissue. Now, abnormal tissue doesn't have to be pathological. There is abnormal tissue that's not pathological. Pathology implies disease. Disease is something that implies abnormal function of a tissue. All right, what time is it? 4:30?
4:37.
We should be done in 5 minutes, doctor. By the way, the patient's doing very well from my standpoint. Surgery's going quite well. This is all scarred nucleus. You see the white stuff? Looks like white caps. That's all scar tissue. And the blue is the nucleus. The gold is calcium. Having a hard time getting lateral because we're so north. You know, the inclination of the disc space is so strong.
Got a question.
I'm sorry?
Got a question.
Yeah, just say we have a question and then say who it's from on what platform.
It's from Teak on YouTube.
Perfect. And then what's the question?
Will the area get inflamed again post-procedure?
Will the area get inflamed again post-procedure? I believe that's what I heard. Is that correct?
Yes, sir.
The answer is no. The answer is no. So I'm removing the source of inflammation. Think about the source as the nucleus pulposus, the herniation, and it's like a little piece of wood that gets stuck in your skin, and it causes inflammation, redness, swelling, tenderness, okay, of your finger. Once you take that wood out, then the wood splinter comes out of your body, then your body just stops being inflamed. It usually takes a day or two, but the inflammation ends. So the inflammation going on here in this disc will literally end right after the surgery. This patient will not have that inflammatory pain anymore. And the only inflammation that will happen here is the healing inflammation. And that's going to take a little while for that healing inflammation to go away. And then there will be no more inflammation because we got rid of the source. The source is the herniation. But it's not the herniation in the epidural space, it's the herniation within the tear that's causing the back pain. Great question. I appreciate you asking. Go lateral again. Great question. So anybody else want to ask? Feel free to ask. That's why we do the live stream, to show you the surgery, what we do, how safe it is, how amazing it is, and then also to answer questions and teach. It's a piece of herniated disc right there I'm releasing with the laser. It's just stuck down to the annular fiber. There it goes. It just took off. It's like releasing a honey badger out of a cage. Huh? The honey badger? I love that video too. It's very funny. It's what I call my wife though. She turns into the honey badger every month. Yeah. That's her nickname. She's not happy about it because the kids are calling her a honey badger too now. It's either that or a werewolf. She definitely doesn't like werewolf. All right, just about done. This should be the end of it. The last part of the herniation and annular tear that we need to fix. So you get, it's all annulus right there that's torn, the white stuff. I'm just cleaning it up, getting rid of the blue stuff stuck to it. It's a fun surgery if you're a surgeon. There's no bleeding really. It's just maybe a cc or two, and then the incision doesn't require stitches. I mean, we put one sub-Q stitch but it doesn't require staples or anything coming out. It's all natural, and there's no implants, no metal, no plastic that goes in permanently. Of course, There's the plastic on the surface of the laser fiber, but that's coming out. We don't leave anything in. About 2 minutes. If you've been told you need a fusion, do the Deuk laser disc repair. You don't need a fusion. Whether it's on your neck or your back. If you've been told you need an artificial disc, you don't need one. The Deuk laser disc repair will fix that disc, so you don't have to replace it with a metal disc. Now the companies that sell artificial discs, they want you to believe you need an artificial disc, but you don't. The companies that sell metal for fusions, they want you to believe you need a fusion, but you don't. They've brainwashed all the surgeons into believing fusions and artificial discs are necessary. The only thing they're necessary for is making car payments, buying that super yacht. But from a patient standpoint, you're much better off not having metal put in your body. So I used to be a fusion surgeon. That's all I did, because I didn't know about this technique until I learned it, started doing it, and finding out that you didn't need to do any more surgeries other than this. This was it. For disc problems, that is. Of course, if somebody has a facet joint problem, you got to treat the facet joints. This doesn't fix facet pain. This doesn't fix piriformis, sacroiliitis, any of the other sources of back pain that are not related to a disc problem. But 90% of back pain comes from a herniated disc, a tear, maybe 2 discs or 3. So when you say I had my disc fixed, you may not have had enough discs fixed. You may need 2. The average for my patients that I've seen is 2.4. That's 2.5 discs per patient on average. So if you just get 1 fixed, chances are you're still going to have pain. But it's not because you didn't need the surgery, it's because you didn't get enough surgery. So learn about the Deuk laser disc repair before you go out and have invasive surgery done. Now that said, we do have a patient having invasive surgery on Thursday called posterior cervical decompression infusion, and it's maximally invasive. So we're going to remove the bones and ligaments from the back of the spine in the neck, and we're going to put in screws and rods and fuse the spine. And you're going to get to see the spinal cord. Pretty cool. Really cool surgery to watch. We don't do a lot of them anymore because they don't need them. I think that's it. There's the nerve root, L5. Maybe just clean this just a little bit. No, he doesn't like that. Done. All right. We are done. Doctor, thank you. It's been nice working with you today. I hope everyone's enjoyed the surgery. The last patient already went home. He was doing fantastic. His leg pain was gone. His back pain that he came here with was gone. He just had some soreness, which is normal from me sticking this lead pipe. But aside from that, his pain was gone. And we're going to need to shoot some testimonials tomorrow. So let's get familiar with room 1. Chet, can you show them room 1? Over on the clinic where the cameras are and the lighting system, and make sure the mics are charged so we can do a couple of testimonials tomorrow. We've got 2 video cameras. I would play with them before you guys go home. Make sure you know how to record. Make sure there's a memory card. Make sure they're charged. Because I want to start doing some more testimonials. It's been a few weeks since we didn't have our videographer for a few weeks. All right, all done. EBL 2 mil. Doctor 2 mils. No comps. We'll have one stitch put in and then we're gonna close up here.
I can take over, sir.
Louise, I think, what I think would be a good idea? If we had something plastic that clips here, that holds it open, like just a little clip, like a circle with a clip, and then have the blue towel going down inside the circle, so then the water would fall there. But the reason why it's on the floor is this is going like this when I'm standing here.
Correct.
But you need something that is going to keep it open. Just something, plasticky. I know we have stuff. Pressure there. Oh, let's show everybody the incision. Can you guys see this? Zoom in right here. Zoom in right here where my finger is. Can you see that? Good. A little lower. Perfect. And there it is. The whole surgery was done through this 1/4 inch incision. Hope you've enjoyed it. We'll be back on Thursday with more surgery. The posterior cervical decompression infusion is a 2-hour surgery. It's outpatient here at Deuk Spine. We're the only place in the world that does it outpatient. So come watch that one. It's pretty cool. All right, Dr. Deuk Majan and my team signing off.